It's really a great honor and pleasure to be here. I was just saying at dinner that the work that you guys do is what is at the center of the ethos and practice of palliative care. It is palliative care. And those of us who are not Buddhist priests or official, formal pastors in that way are borrowing from your tradition to do the work that we do with patients. So it's a sort of coming home. So I'm hoping that I'm going to use some slides to illustrate things, but I'm hoping that we'll be able to talk to each other during this evening as well. And I'm just going to say that I have no conflicts of interest. And I want to begin with just a reminder of what we have all witnessed and what some of us have been through in the last 2 weeks. This is a shot from space of Hurricane Sandy. You can see how big it is. It's 1,000 miles wide. This is a shot of where taxis sit in New York City. This is the Atlantic City Boardwalk, which is no longer there. This is the Lower West Side of Manhattan, under the West Side Highway. This is the Lower East Side of Manhattan. This is New York with no power, downtown. Power went back on Sunday for Lower Manhattan, but is still out for large parts of the metropolitan area and very large parts of New Jersey and Westchester. There's been a great deal of loss and suffering associated with this storm. This is a kid in front of his house. These are the homes in Breezy Point that in the midst of a hurricane, because of explosions of tanks, there was this completely out of control 6-alarm fire that, although it was raining and water was pouring in, was uncontrollable. I think it's not hyperbolic to say this was an apocalyptic, almost biblical series of events, and this is what it looked like afterwards. This storm did not only occur in North America, but very much affected those least able to handle it in the Caribbean. This picture and the next one are from Haiti. Didn't get much attention in the press. This is a man in Queens. This is the New York Times article about some of the people, not all of the people who died during this storm. This is a photo of a 23-year-old who was out with her boyfriend walking the dog when a tree fell on them, and they both died. And they were found the dog stayed with them all night, and they were found the next morning by someone going out with their dog. Just one of now over 100 stories just in the United States. So it's obvious the world is full of suffering. But as Helen Keller said, it is full also of the overcoming of it. And this is from an essay she wrote called Resilience in about 1900 that you can find on the internet, which I recommend to you. And here's the resilience that we saw in the human community after Sandy. I like this picture because my dog looks just like that, with the gray chin and everything. Children being rescued, families being rescued in boats. This is the 86th Street and Lexington subway station that most of us take to work. It's like 20 blocks from Mount Sinai. And here's a relevant quote that I found during the storm from Albert Einstein, where he said, "Every day I remind myself that my inner and outer life are based on the labors of other men and women, living and dead, and that I must exert myself in order to give in the same measure as I have received and am receiving." So I just wanted to start by acknowledging what just happened. And the objectives that I want to talk about for for this evening are, first of all, to review with you how did we get to this place in healthcare in 2012? How did we get here? It didn't just happen. And where are we now? And I would argue that palliative care is at a remarkable historical tipping point with a huge, wide open window of opportunity for the kind of work that we all do. And then how do we get there? Where should we go? And how do we get there? And obviously a big piece of it is bringing the ability to be present into the work of health professionals and patients. So if you go way back to the Middle Ages, like the 1400s or the 1500s, the first hospices were actually places where the Crusaders stayed on their way to the Middle East to fight. They were not places for the sick. But then several hundred years later, church groups and church leaders, first in London but in other European cities as well, established hospices for the poor and sick. Only if you were poor did you have to go to one of these places. Everybody else stayed home with their family. So it was only for the least among us who were ill and had no one to care for them. And until really less than 100 years ago, all deaths occurred at home and were a very common part of life. And there's a whole sort of field of art or term of art called ars moriendi, which is the art of dying. People thought a lot about what their death should be like, what they were going to leave behind, what things was important to say to their children or their husband that they were leaving. Death was commonplace. Many, if not a majority of children died before reaching childbearing age. It was just at the center of the human experience. And around it, therefore, was a lot of ritual to help individuals and communities heal from this loss of one of their number, which, at least in my lifetime, I've never been exposed to and never seen. So in a very short period of time, what for all of human history was a central, shared, social experience disappeared in the blink of an evolutionary eye. And this is why. And what this slide shows in the x-axis is, I can't remember which comes first, the Stone Age or the Paleolithic Age, but anyway, a long time ago, 30,000 years ago, when humans first walked the earth, life expectancy was 30. And it stayed around 30. It was almost like random death in the wild. You could die in a storm, you could die of an infection, you could die because somebody killed you. Life was very dangerous, nasty, brutish, and short. And it really wasn't until the major intervention that occurred that started the gain in life expectancy first was the ability to have agriculture, to be able to grow food. But the second major leap up in life expectancy was simply the recognition of the germ theory of disease and the recognition that drinking water had to be separate from sewage. And that led to a 20 to 30-year gain in life expectancy in a very short period of time. I just want to point out to you that it has absolutely nothing to do with modern medicine and occurred long before modern medicine as we know it came into play. But it had an impact on it allowed modern medicine to exist because now that people were living past the age of 30 or 40, there was a market for healthcare that hadn't existed before. And in fact, right now in this country, the median age of death is 78 years, a bit less for men, a bit longer for women. And while it has, for the most part, been increasing in recent years, it started to go down. And specifically for certain populations, you might have read that white men who didn't finish high school have had a very significant decline in life expectancy in the last few years. Among those of us who make it to 65, amazingly, most of us will live to 85. Half for longer than that. I mean, I don't know if that's good news or bad news for all of you in the audience, but it's a fact. So, and among those of us who make it to 85, most of us will live at least another 7 years. So when you think about evolutionary change, very rapid, dramatic, almost incomprehensible evolutionary change, that's what we've seen in the last 100 years, which is no time at all in human history. Gain of 30 years just since 1900. And the New Yorker's having a good time with this. This cartoon says the knees are the first thing to go. And since my knees will no longer let me run, I appreciate this cartoon. His knees are down at his ankles. So what happened? All of a sudden, there was no longer an expectation that death was normal or routine. In fact, death is the exception. Perhaps with enough research, death itself should be defeated. And in fact, if you look at the NIH, the National Institutes of Health, which have billions of dollars in taxpayer money, you could be forgiven for thinking that the mission of the National Institute of Health is to defeat death, is to eliminate death from all causes. They essentially say that, as if somehow that is a rational social goal. But most people think it is. I mean, I'm not saying this to be funny. This is the society in which we live, in which death, the defeat of death, the prevention of death, is seen as a rational social goal. Think about that. If you actually thought that through, what the consequences of that would be. So that's what we're up against here, just in case you thought this was going to be easy. So everyone thinks they should have a long life, that they deserve a long life, that it's normal to have a long life. And because it created essentially a market for medical care, we've seen exponential growth in hospitals, procedures, medicines, technology, health insurance to pay for all of it, NIH funding, and the market forces that have both caused and been the result of this huge growth in an industry. So what happened? Some people saw this as maybe not an unalloyed good. Interestingly, most of them were women, middle-aged women. Cicely Saunders, who after World War II was initially a social worker, then a nurse, working with a pain expert in London, who told her that if she wanted to have any real power and authority, she had to go to medical school. So she did. So she was a social worker, nurse, and physician, one interdisciplinary team in one person, and also a very spiritual person. She established St. Christopher's Hospice almost entirely with charitable money, no money from government, in 1967. And she was friends with Florence Wald, who was the dean of the Yale School of Nursing at the time. And Cicely came and gave grand rounds at the Yale School of Nursing, and then Florence went back to St. Christopher's and spent a sabbatical there to study. And then she came back to Connecticut and established the first hospice in the United States, the Connecticut Hospice. Right around then, Elizabeth Kubler-Ross, who was a psychiatrist at the University of Chicago, did this very revolutionary thing. Do you guys know what she's remembered for? She's remembered for the least important thing that she did, the 5 stages of grief. It's so interesting that that's what she was remembered for, but actually her book is so powerful because all it is her listening to patients and families and quoting them, asking them about their experience. You can't find another book that is devoted entirely to the voices of patients and families, the way that one is. And that's not what she's remembered for, but it's what she should be remembered for because it was so revolutionary. The patient had all but disappeared. The patient was the object or the means for this marketplace to go on, but was no longer at the center, and she put the patient back at the center. We owe her a huge debt of gratitude for that. Most of the hospices that grew in the United States were grassroots organizations led by volunteers from faith communities, church groups, synagogue groups. They were not part of the medical establishment in any way. They were countercultural. And they almost entirely focused on one disease, cancer, as if somehow that was what everybody died from, even though even then that was not what everybody died from. But the model was designed around the needs of cancer patients. And this is a picture of Cicely Saunders and one of my favorite quotes from her in which she said, "It appears in a masterpiece of understatement, that many patients feel deserted by their doctors at the end. Ideally, the doctor should remain the center of a team who work together to relieve where they cannot heal, to keep the patient's own struggle within his compass. I love that. You know, it's the patient's compass that we have to understand, and to bring hope and consolation. And then Elizabeth Kubler-Ross, her book has been translated into 17 languages and reprinted thousands of times. Really powerful and important book because it basically took the experiences of the seriously ill and dying out of the closet and gave them a voice. And here's another of my favorite quotes. This is Kubler-Ross saying, "I say to people who care for people who are dying, if you really love that person and want to help them, be with them. Sit with them. You don't have to talk. You don't have to do anything, but really be there." And there's Florence Wald. So the result of all their work, the good news and the bad news, is that we got a federal benefit to pay for this. So the good news is that led to an exponential increase in access to hospice because there was money to be made doing it. There was a way to support these programs. There are now over 5,500 hospices in the United States, of which 70% are for-profit. So it's a big industry and rapidly growing. So it had many positive effects. It let people stay home. It had a focus on the person, the patient as a person, and their family, not just the patient. And it led to very substantial improvements in quality of life and ability to remain in control of your life during a serious illness. But the weaknesses are also quite profound. By law and by design, it's only for people who have a prognosis of less than 6 months. Now, those of you who have worked in healthcare will know that we have no idea who's going to die in 6 months. Absolutely no idea. Even in cancer, we don't know who's going to die in 6 months. We don't have a good sense of prognosis usually till a few weeks to maybe a month or two before death. So the design of the benefit bears no relationship to the reality of the human condition. That's the first thing. And the second thing is that people have to sign a piece of paper giving up their right to insurance coverage for treatment of their disease in order to get the hospice care. So I've had many patients say to me that it feels like they're being asked to sign their own death warrant. They're being asked to sign a piece of paper that says, "I know I'm dying, uncle, so I agree I'm dying and you don't have to take care of me in the hospital anymore. And in return for confessing these sins, I will get hospice care." It's quite, it's cruel, actually, in my view, what we ask patients to do. And obviously it doesn't fit for chronic disease. Does anybody here know how many of us die of cancer in the United States? What percentage? It's actually fewer. It's 22.6%. So 78% of us do not die of cancer. Alzheimer's, stroke, heart failure, emphysema, end-stage renal disease, transplant, frailty, debility, where we have no idea when you're going to die. So all of those people are essentially inappropriate for hospice because we can't predict their time of death. And in fact, when hospices, to their enormous credit, tried to extend palliative care to chronically ill populations who were not predictably dying, they got slammed for fraud and abuse by the federal government and have now become extremely sensitized to that risk and much less likely to take patients in who are not clearly dying. And this is a quote from the New York Times in 2007. "Hospice providers across the country facing the catastrophic financial consequence of what would otherwise have seemed a positive development. Their patients are living longer than expected. The refusal of patients to die according to actuarial schedule has led the federal government to demand that hospices repay hundreds of millions of dollars to Medicare. And hospices are under a constant magnifying glass for fraud and abuse. And some of them are fraudulent and abusing the benefit, especially some of the for-profits in the south of the United States. But the entire industry has been basically hogtied by this, so that patients that need hospice care, would benefit from hospice care, turned away because they're not actively dying. Okay, so clearly hospice was a piece of the solution, but not the entire solution, because it doesn't deal with people who are not predictably and obviously dying. So a bunch of private sector philanthropists like Robert Wood Johnson and George Soros came into the business in the late 1980s and early 1990s. And the first thing that Robert Wood Johnson did was support something called the Support Study, which was a huge study of over 9,000 patients with serious chronic illness. And what they found, and this was front page news in every major media outlet in the United States, was that fewer than half the doctors had any idea what their patients wanted. About 40% spent at least 10 days in an ICU during their last hospital stay. Half had moderate to severe pain half the time in their last 3 days of life. In their last 3 days of life, by the way, we do know that you're about to die. So what's the excuse for this? 40 to 60% reported moderate to severe pain after over a week in the hospital, when there'd been plenty of time to evaluate and respond. And over half of families experienced a major adverse impact, whether bankruptcy, loss of employment, serious illness in a spouse, et cetera. So this had a very marked effect on the body politic and the collective unconscious. And you started seeing cartoons like this one, which is a garage, and the mechanic is saying to the car owner, if it were my car, I'd disconnect it from the battery recharger, take it home, and let it die in its own garage. This sort of started, the zeitgeist of maybe modern medical care wasn't all it was cracked up to be, started to emerge in cartoons and in TV drama. And I have to say, our entire field of palliative care, and initially of hospice, is entirely the result of private sector philanthropy investment and strategy. Government had almost nothing to do with the development or inception of either of these fields. So I want to give a shout out to private sector philanthropy for doing really providing critical social services to our entire country. And initially it was mostly Robert Wood Johnson and Soros at the Open Society Institute, but there are literally hundreds of other foundations across the country and in other parts of the world that have invested very heavily in improving the experience of serious illness. Robert Wood Johnson, just a few examples of what they did. They paid for a physician curriculum called EPIC, a nursing curriculum called LNEC. They gave David Weissman money to develop curriculum that sits on the web that anyone can take and use to teach. They tested a whole bunch of different models of delivery of palliative care, prisons, Alaskan Natives, in the Promoting Excellence project that was led by Ira Byock, who I'm sure most of you have heard of. They looked at textbooks and journals and found that the major leading textbooks in medicine and nursing, you could read the whole textbook and not know that anyone died of any of these diseases, and not know that any of these diseases caused pain or suffering or distress. It just wasn't in there, completely absent. And what they did, RWJ, is shame the publishers. They wrote them letters and they pointed out to them, for example, that the leading cause of death in this country is heart failure. But in the cardiology textbooks, there is no death from heart failure. There is no shortness of breath. There is no fatigue. There is no depression. There is no family caregiver burden. So now if you look at all those textbooks, they all have content in this area. And that's really important. This is how students learn. Same is true for journals. If you look at the leading journals now, New England Journal, JAMA, and others, they routinely carry publications on palliative care issues that were nowhere to be found 10 years ago. Again, because of pressure from the private sector. They funded my organization, the Center to Advance Palliative Care, in 1999 to help. They asked us to help other hospitals develop palliative care teams like we did, and they invested over $160 million over a 15-year period, a very large chunk of change. Then George Soros, based on his experience with his parents' deaths, one of which he thought was not good, and the other one he thought went somewhat better, decided that with a big investment of cash, he could change the experience of dying in the United States. He is nothing if not self-confident. But what they did was different. So I showed you that RWJ invested in content, like curriculum for doctors, nurses, and others. What Soros invested in was leaders. And it wasn't like they thought this up, that one would do content and the other would do leaders. But together, this was an incredibly powerful, aligned series of investments. And many of the major leaders in the field today got their start from Soros and the Open Society Institute. Project on Death in America was the name of it. I mean, we got salary support and we got to work with like-minded professionals from across the country. Tony Bach was a fellow faculty scholar of mine, and he and I are still working today with the people that we met as faculty scholars in 1995. And many of them continue to lead and advance the field. So this was, I think, a truly transformational strategy. And it involved not only doctors, but also nurses and social workers. So where are we now? That's the past. That's how we got to where we are now. So thanks to these investments, there are now over 1,700 hospital palliative care teams in the United States. That's the good news. The bad news, they are of highly variable quality and penetration and impact. So you can say you have a palliative care team if you have a 0.2 FTE MD who comes in after office hours. In my view, that shouldn't count, but it counts. We need to bring everyone up to a higher standard. There are new subspecialties in medicine and nursing in the last 5 or 6 years. Highly variable, I think everyone would agree, highly inadequate exposure to training for medical students, nursing students, social work students, chaplaincy students, and graduate education. So you shouldn't be surprised that your doctor or your nurse knows nothing about the management of pain and nothing about how to conduct a conversation about what to expect. He or she has never been trained to do so. And that is still the case. And what we are also seeing presently is a changing cognitive frame for palliative care that moves away from brink of death care and away from cancer as the model to recognizing that palliative care is good quality care for anyone with a serious illness, whether they're going to be cured, live for 20 years or 30 years, or have progressive illness. So it's a much broader frame of reference for palliative care than we've ever seen before. This is a graph showing the growth in hospital palliative care in the last 10 years. And this is the new cognitive frame for palliative care where from the point of diagnosis of a serious illness and throughout the course of that illness, whether it's 3 months or 30 years, the patient receives both palliative care focused on quality of life and whatever disease-directed therapies are appropriate, with hospice referral occurring over here. Why over here? Because this is the point at which either disease-directed therapies are no longer working, that is, they're not helping the patient, or their burden outweighs their benefit. And that's the rule for hospice. You can't get both. But in palliative care, you can get both. And so this would apply to someone, say a 23-year-old with acute leukemia who's going to be cured with a bone marrow transplant, but is going to go through hell with the diagnosis and treatment. And then when she's cured, she says goodbye, and she never sees any of us again, hopefully. But the vast majority of the patients we serve are chronically ill and living for a very long time with debilitating illnesses. So that new cognitive frame has led to a new definition for palliative care. And this is the definition that I encourage, plead with you to use. It does not refer to prognosis. It does not say anything about dying. It doesn't say anything about giving up one kind of treatment in order to get palliative treatment. The key points here is that this definition was tested with a public audience, 1,000 likely voters, about a year ago. And we asked them to rank what they thought were the most valuable components of palliative care. And then we took basically the top 15 most valuable components and put it in a definition. So they liked the term specialized medical care, the public. My nursing and social work colleagues do not like that term, but the public liked it because it's reassuring. Oh, it's like cardiology. Oh, it's like oncology. For people with serious illnesses, interestingly, advanced illness equals terminal in the public's eyes. They know what the euphemism is. This type of care is focused on providing patients with relief from the symptoms, pain, and stress. They didn't like relief from suffering. We use the term suffering all the time. That's inside baseball. The public and patients and families, the term suffering has a very kind of death pull to it and an end-of-life pull to it. And if that is not the way the patient or the family articulate what they're going through, we should not impose that language on them. So symptoms, pain, and stress, everybody gets that. Whatever the diagnosis, the goal is to improve quality of life for both the patient and the family. Interestingly, both patient and the family was the #1 ranked characteristic of palliative care, ranked higher than anything else in this definition. Palliative care is provided by a team, and I thought team would be a negative because don't these people have enough strangers in and out of their room or in and out of their life? But teams seem to imply communication to the public, like that we were actually talking to each other, and they recognize that that's important, so they liked it. And then they really liked this work with a patient's other doctors. It's the opposite of what happens in hospice, where you lose your whole team, and you move over to a brand new team at the time when you can least afford to lose your team. That's how we've structured it. And to provide an extra layer of support. And if you're looking for an elevator speech about what palliative care is, it's the extra layer of support. If you've got 3 seconds, that's the definition. Everybody understands that you need an added layer of support in this broken healthcare system. It's very easy to understand. It's not taking anything away. It's not asking people to give anything up. Palliative care is appropriate at any age and any stage and can be provided at the same time as curative or life-prolonging treatment. Now, when we then took this definition back to the public, the positives were so high that the pollster, who is Bill McInturf, who some of you may have heard, he's a Republican commentator and pollster. We deliberately chose a Republican pollster because we wanted to make sure these data would feel legitimate to both sides of the aisle. He said these numbers were embarrassing, that most of his colleagues think he made them up because a high positive for public opinion polling is in the high 60% range. You don't ever see public opinion in the 90% range. But for palliative care, whether you were a Tea Partier or a progressive, everybody wants it when it was defined the way I just defined it for you. No issue with death panels with that kind of definition. So the 3 goals of palliative care, obviously the relief of physical, emotional, and spiritual distress, expert communication about what's happening, what to expect, and then skilled coordination across all the different settings that patients traverse during a serious illness. And what else have we found? Because there's been research done in palliative care, and you see it in the journals now, and this never happened before the last 10 years, we actually now have a growing body of evidence that not only do we know in our hearts that it's the right thing, the scientific evidence shows that it improves quality of life, prolongs life, and markedly reduces the risk of ending up in the hospital for patients and families. And these are the different outcomes that have been proven through lots of scientific studies to get better with palliative care. There are very few other interventions in the healthcare system that you could say this about. So this is an important study that colleagues of ours at Mass General did that was published last year, and I want to actually ask you why you might think this is. These were lung cancer patients who were newly diagnosed, who were randomly assigned to get excellent cancer care only in the control group, or in the intervention group to get excellent cancer care plus palliative care from the point of diagnosis. Well, I'm sure it will come as no surprise to you, those who got both had better quality of life, lower rates of depression, were much less likely to be hospitalized in the last month of life, to get chemotherapy in the last month of life. But to everyone's surprise, they also lived 2.7 months longer. This also hit the front page of all major media outlets, not because of the other things I told you, but because of better survival. So let me ask you, when doctors see this study, the reaction of my colleagues at Sinai was to call me and say, Diane, did you see that paper? That can't be true. So physicians believe that with palliative care, you are going to live, you will die better, but you will die sooner. There's no data to support that, but that is the firmly held cognitive frame of doctors. So yet when I show these data to regular people, the public, it's like so obvious. They look at me like, what's the big deal? Of course people would live longer if their quality of life was better. So there's this huge disconnect between the profession and everyone else who understands this kind of in their bones. But let me ask you, I did something wrong here. If you had to explain what the mechanism of action might be, let's say we can replicate this, what might be the mechanism of action for living longer with palliative care along with regular cancer care? Happiness. How does what's the mechanism by which happiness might prolong life?
More relaxed, less stress on the heart. Just joy, endorphins. I don't know.
See what I mean? It's obvious to everybody except the doctors. But all right, so that's one reason. And in fact, we do know that depression, in contrast, is an independent predictor of mortality. So if you have a stroke and you're depressed, you will die sooner. If you have a heart failure and you're depressed, you will die sooner. If you have Alzheimer's disease and you're depressed, you will die sooner. Depression kills. So there was a lot less depression in the palliative care group. They were happier. That's the other way of putting it. So that's one thing. What else might have contributed? Sorry? Better symptom control. So why might that lead you to live longer?
I mean, if somebody's depressed, a lot of times people, depressions aren't treated when they're thinking of having actual cancer care, but also pain and any other kind of physical symptoms.
So pain also kills, and shortness of breath also kills. And whether it's because it is so stressful and all of your body's energy and focus is on bearing it, and it takes away whatever you might have other resources for. It's not clear, but there are some data that are suggestive that intense symptoms also kill, in addition to depression. So that's a second possible reason. What else?
Personal human connection.
Interesting. Personal human connection. What might be the mechanism of action of that? Like, this is what the doctor's going to say back to you. What do you mean? This is all touchy-feely. What's the mechanism of action where personal human connection?
Neuroimmunology.
Yeah, precisely. So there is an increasing body of evidence that mood impacts the immune system. Some people still reject it as too touchy-feely, but I showed these data at a talk at a medical school in Cincinnati. And for some reason, there were basic scientists in the audience, which is unusual. And we were talking about this study, and one of them stood up in the back, and he said, well, yeah, last year in Cell, which is a very prominent journal for bench scientists, there was a study of mice who had been transplanted and were immunosuppressed. And the mice were randomly assigned to kind of best animal practice, clean cages, but they were in the cage by themselves. They had this clean, they got food when they were supposed to get food, but that was it. And the other group were randomly assigned to a much more interesting environment where there were a lot more shavings and pieces of cloth they could make and burrow with. There were toys. There was more handling and talking from the lab staff. There was ad lib access to food, and there were other mice. And the intervention group lived 4 times longer than the control group. So what this basic scientist said to me was, we looked at each other, meaning he and the other people in his lab, and we said, we're wasting our lives. Because what had the biggest impact on survival was not the drugs. It was stuff that everyone in the real world understands are so critical to well-being. So I can't help but laugh, but let's see. Okay. That's the one thing we didn't get to, and that's exactly right. So what do we know about being in the hospital if you're sick? It's dangerous. It's really dangerous. If you do not absolutely have to be there, you should get out. And the reason is not because people there are not trying hard, not because they don't care about you, not because they're not doing their best, but the risk of error, the risk of serious infection, the risk of falling in a strange place or becoming confused in a strange place or having your meds mixed up is very, very high. And there are over 100,000 deaths per year in this country that occur because someone was in the hospital, as opposed to what would have happened had they not been in the hospital. And imagine if you're a lung cancer patient and you're immunosuppressed with chemotherapy and radiation, and you go in the hospital and you get a C. diff infection, you die. So the risk to very vulnerable populations is even higher than it is for those of us in this room. So yes, not avoiding the hospital, I actually think is among the most powerful explanations for this gain in life expectancy. Now, again, this is really hard to get across to the public. People persist in believing that the hospital is the one safe place. And we got to figure out a way to change that cognitive frame among the public because it's actually not safe. How do we think about palliative care in the national context? So we are living in a society in which the quality of medical care is among the poorest on the globe. We rank 40th in quality indices among other nations, 40th in infant and maternal mortality, 40th in rate of preventable mortality. As I said, there are 100,000 deaths per year in hospitals from preventable medical errors. 1/7 of our population is uninsured, has no access to health care, and health care is the #1 cause of personal bankruptcy in this country, but in no other developed nation is that the case. And as perhaps was not talked about that much during the election, but is very clear to everyone, healthcare is the #1 cause of the decline in American society because we're spending almost 1/5 of our economy on it at this point. And the New Yorker, as usual, is tracking these trends. And here's a doctor saying to a patient, according to your carrier, this little piggy has insurance, but this little piggy has none. And it's actually not all that far from the truth. There was an interesting piece on some blog that a Harvard health economist wrote about how she was a person who wrote about health insurance and really understood health insurance, but she had the wrong health insurance when she got a bad diagnosis and couldn't get the care she needed or had to pay for it out of pocket because she had the wrong health insurance. And increasingly, you see articles like this one. This was in Florida last year. Medical bills push family to bankruptcy. This was a baby born with a congenital abnormality, had 2 upper-middle-class professional employed parents, 2 health insurance policies, got to the, what's it called, the limit, the spending limit on both of those policies, bankrupted her family. They lost their home. She died at age 4. This really should be appalling to us that this happens in our country, but it routinely happens in our country. Does not happen anywhere else in the world, or certainly not in any other developed first world nation. This is a graphic from Massachusetts titled Healthcare versus the Determinants of Health. It's a great title. So this is Massachusetts spending on different buckets between 2000 and 2012. And on the left bar going up, you see there's been about a 75% increase in healthcare spending. And you see what's happened to everything else. Education, public health, the environment, parks, recreation. Because in states, you have to balance the budget, unlike the federal government. You cannot borrow. So if you're spending more on healthcare, everything else has to be cut. Fewer police, fewer firemen, etc. And here's the New Yorker again. You're in luck in a way. Now is the time to be sick while Medicare still has some money. So those of you who are 55 or under, watch out. Those of us who are over 55 will do better. So my view is that palliative care is central to the nation's future because we take care of the sickest and most complex patients who also happen to account for 50% of all healthcare spending. So we're sitting right at the center of the bullseye. Our patient population is the most vulnerable to poor quality care and the most expensive. So who do you think is going to get targeted for all these cuts? Our patient population. As it happens, we improve their quality while reducing their costs. So we really are the solution here. We've got to stop seeing ourselves as marginalized and unimportant and start seeing ourselves as the center of the future of the healthcare system. And here's an example. This was a patient of my colleague, Dave Casserat, 79-year-old woman admitted through the emergency department for management of pain due to metastatic lung cancer. Pain was 8 out of 10, on admission for which she was taking Tylenol. She had been admitted 4 times within 6 months for pain, twice for pain, once for nausea and dehydration, and once for altered mental status. Her 87-year-old husband is overwhelmed. She said, "I told the doctor that I never wanted to go back to the hospital. It's torture. You have no control and can't do anything for yourself. And you get weaker and sicker. Every time I'm in the hospital, it feels like I'll never get out." And Mr. S., she hates being in the hospital, but what could I do? The pain was terrible and I could not reach the oncologist. This oncologist actually had a, if this is an emergency, call 911 on the tape, so that's exactly what they did. I couldn't even move her myself, so I called the ambulance. It was the only thing I could do. Now, this patient eventually got a home palliative care program where she lived another 6 months continuing to get chemotherapy and then got hospice for the last month of her life after that. So these are the challenges for patients and families. No coordination, lack of support, no attention to goals or preferences, poor symptom management. But what about the healthcare systems in which they get care? Their care is very costly. They are frequently put in the most expensive setting. Their care, they hate being there, like Mrs. S. said. And right now, thanks to health reform, hospitals are actually being financially penalized for frequent readmissions and death in the hospital. So all of a sudden, we have leverage because we can now help hospitals avoid those penalties by helping people stay safely at home. So the future of palliative care, not enough to have access in hospitals, which is where we've got it now. As you guys know, most illness occurs at home and in communities. We need home palliative care without regard to prognosis or goals. It shouldn't matter how long you're going to live. It should only matter what your need is. And so the goal of our field for the next 10 years, the next stage of development of our field, is to ensure access to palliative care across all settings, all stages of illness, no matter where you live, no matter what color you are, no matter how old you are. And the way we're going to do that is by achieving 3 goals. The first is by improving public awareness of palliative care so that they start demanding it. Demanding it of policymakers, demanding it of us, the providers. The American Cancer Society is actually helping us with this public awareness campaign. This is an ad they put in Politico, which is a Capitol Hill thing that all congressmen and senators and staff read every day religiously. So this ad, you can see in the black Arial font, it says cancer. But then there's a purple vertical, and it says dancer. It's really powerful because it makes the point that this person is a dancer, right? She has cancer, but as the person is a dancer. And this got a lot of attention from people on the Hill. And our organization has actually created a public website for people to go to find out what palliative care is and to get access to it in their community. And the way that people get to this website is, say they have cancer, they go to the American Cancer Society, and there's a link on the cancer website to this because people search under their disease. The second goal is education. And interestingly, we heard discussion about how that's one of the goals of this center. And we've got to get to a point where health professionals have the knowledge and skills to provide this kind of care. And here's one of my very favorite New Yorker cartoons. This was the caption contest. So it's a dead person in a coffin, and the doctor's facing his computer the other way. And the 3 captions were, any stiffness? Sorry about the wait. And any family history with death. So I really like this cartoon because actually most of my colleagues do not know how to identify the fact that someone is dying. So they go to the ICU because they're getting worse. They literally don't recognize the syndrome because they haven't been taught to do so. So this cartoon is right on the money. Why is it so bad? Why are things so bad? Medical students, residents, fellows get virtually no exposure to good practice, good palliative care practice during serious illness. Mr. Bromley, nice to put a face on a disease. That's how we're taught. We are, it's the lung cancer patient in bed 3. It's much more about the disease than it is about the person. And that's what you get when you're a patient. So these are the priorities for workforce. We've got to train more people in palliative care. We've got to make it easier for people in the middle of their career who are not going to go back and do fellowship training to be able to get training and enter the career. And we've got to make sure that currently practicing doctors and those being trained and nurses all have core competencies in palliative care. We can't depend on specialists to take care of this. And again, here's a doctor saying to a patient, there's no easy way I can tell you this, so I'm going to send you to someone who can. I do want to rush to point out to you that those of us in palliative care think this is a great doctor because he knows what he knows and he knows what he doesn't know. And he knows what colleague to call. He'll call Craig on the phone to talk to this patient because he knows that Craig will spend the 45 minutes to an hour explaining the options and the pros and the cons and matching them together with this patient's values. Not only does this doctor not know how to do that, he's got 50 other newly diagnosed cancer patients in his waiting room that he has to see. So it takes a team. But palliative care has a procedure too. Even though we don't do colonoscopy or angioplasty or infuse chemotherapy or operate on people, which is how you get paid in the healthcare profession, we have a critical procedure. And I don't want to imply here that this is easy and doesn't require training. And I think everybody who's at this conference understands just how hard it is. It is rocket science. It is brain surgery. It's hard. It takes training. It takes practice. And that's what you're here to get. I ask this question a lot once I've gotten to know a patient or family. How are you feeling inside yourself? I keep a journal of the answers. One of my patients, an African-American matriarch who was the center of her church and the center of her extended family, and had a breast cancer that was so advanced when she came in because she hated doctors and hated hospitals and was never seen, that there was very little that we could do medically to prolong her life at that point. But this is what she said in answer to that question: I'm talking to God. Others, I don't think I can take this pain anymore. I am so worried about my family. I wish I could get away from all this. I am not sure how my husband will manage without me. I want to go home. I'm at peace. I've never had somebody say to me, I want to be cured. I've never had somebody say to me, I'm terrified of dying. I ask this question all the time. Huge range, but you see, the answer takes you to where the person is, right? And when you're where the person is, you can be present with them in that place. But you have to ask the right question. If it's, how's your pain on a scale of 0 to 10, and that's what you're asking, you'll get a number. And there's not only patient suffering, there's very importantly professional suffering. And I want to tell a story that taught me a lot. This is Judy Friedman, who was a patient of mine a few years ago. She was 65 years old, a psychotherapist in active practice. Diagnosed at age 59, no smoking history, initially given a prognosis of about a year, lived 6 years, partly because she was just lucky, partly she had a great oncologist whom she was devoted to and adored. She, about 2 years before she died, she found me on the internet and came to see me at a different medical center because she recognized that her oncologist was unable to talk to her about what might happen if the treatment stopped working. And she was somebody who wanted to know. She wanted control. So she found me, and he and I co-managed her for the last 2 years of her life. And I worked on things like fatigue, pain, talking to her daughter and her husband. And when her disease started progressing, in spite of everything that the oncologist had tried, she went to hospice for only 3 weeks and died very peacefully at home on hospice. And that's Judy with her daughter. And this is to sort of put you in the frame of mind of her oncologist. So this is a cartoon in the graveyard. One sign says their own fault, another sign says nobody's fault, and the third sign says somebody else's fault. And at the top it says all you need to know. This is how we're taught. If a death occurs, it's because we screwed up or we failed to do something. All right, so here's what happened with Judy. So the oncologist, when her brain mets were progressing, she had headache and she was having difficulty concentrating. He offered her the placement of a reservoir in her brain to give what's called intrathecal chemotherapy directly into the metastatic lesions of the brain. And this, I think, was the most profound learning experience of my career and maybe my entire life so far, this conversation. Judy came to see me and said, Dr. C suggested that I have intrathecal chemotherapy. What do you think? So I swallowed my cause. I'm old enough by now to suppress the urge to say, that's absolutely ridiculous. What is he talking about? So I said, you know, Judy, I don't know. This is not my area of expertise. But I'll call him and we'll talk about it, and one of us will get back to you. So I called him, and I said, you know, Dr. C, Judy was in to see me today. She mentioned that you had recommended intrathecal chemotherapy. I don't have much experience with this procedure. What are you hoping we can accomplish for her? Completely without judgment. Open question, right? He said, it won't help her. So I really had to swallow my cause at this point. Self-awareness, self-knowledge, knowing that what you're feeling is not always what you should act on. There was a long pause. And so I did the judo thing. I reversed my impulse and I said, do you want me to encourage her to go ahead with it? Because that's what she had come to ask me. And here's what he said. I don't want Judy to think I'm abandoning her. Do you see why this was such a profound moment for me? It completely shifted my perspective on why my colleagues sometimes do things that make absolutely no sense to me at all. This doctor loved Judy, was totally devoted to her, had pulled magic out to keep her going for a really long time, and had no more oncology treatment to offer her, and literally had no other means of expressing his love for her. So he offered her a futile treatment because it was the only arrow in his quiver. So as soon as he said that, this is interesting, this is about the power of self-awareness and naming feelings. As soon as he said, I don't want Judy to think I'm abandoning her, he said, we're not going to do that, right away. Because he wasn't conscious of what was motivating his behavior until I asked the question. And he answered it. What happened after that, this is Judy and her husband and daughter about 6 months before she died on a trip to Europe. What happened after that was that she was home on hospice and becoming homebound. And on one of my visits there, you know, I asked her how she was feeling inside herself, and she said, I'm really angry at Dr. C. He has not called, he has not come to see me. And it's so interesting that her whole inner life was being spent trying to understand this betrayal by this doctor who she was devoted to and adored. It wasn't being spent on her parents or her husband or her daughter or her book group, or it was about the doctor, the feeling of betrayal by the doctor. Why isn't he coming to see me? Why hasn't he called? So after a conversation, she agreed to let me call him, and I called him and I said, you know, Dr. C, Judy really wants to see you. And he said, why? I can't help her. Still believing that the only thing he had to offer was cancer treatment. And I said, actually, she wants to thank you and she wants to say goodbye. She really loves you. And he went, he made his first home visit. And saw her, and she was a different person after that, much more peaceful, much more able to be present. And this is Judy when she was getting hospice care at home after her doctor, her oncologist visited her. So that's, education is just critical for all of us. And goal 3 is that all hospitals, nursing homes, home care agencies, doctors' offices should have the capacity to deliver this kind of care. And the model should be that we have hospital services, inpatient units, outpatient clinics, cancer center palliative care, outpatient primary care clinics, nursing home services, and home care. So this is the vision, that wherever you go, there's palliative care. You shouldn't have to be in the hospital or be in hospice. It's just part of what you get when you have a serious illness. So here's Isaac Asimov, life is pleasant, death is peaceful. It's the transition that's troublesome. That's what we're here for. And I love this quote from William Gibson, who is a sci-fi writer. The future is here now. It's just not very evenly distributed. So that's why your scaling work is so important, so that it becomes evenly distributed. And thank you all for your work on all of our behalves.